Good evening, everyone. Welcome to our third EPIC training event of the academic year. I'm Julie, Project Director for EPIC, and I'm shouting out a big thank you to the team behind the scenes as usual. This, of course, includes Wendy Myers, our Grant Program Coordinator, Ryan Brasa, our Graduate Assistant, and Sarah Fisher, our Research Assistant. We're so excited tonight. Let me tell you about our presenters before I stop sharing. So Dr. Ebony White is a licensed professional counselor, a national certified counselor, and an approved clinical supervisor. She's an assistant clinical professor in the Department of Counseling and Family Therapy and the program director of the Masters in Addictions Counseling program at Drexel University. And Dr. White's going to share a little bit more about her background when she gets on, and we have a more extensive kind of bio for Dr. White on our website. Dr. Sarah Wenger has been a professor at Drexel University's College of Nursing and Health Professions since 2007. She is the coordinator of academic integration at Stephen and Sandra Scheller 11th Street Family Health Services, an interprofessional community-based federally qualified health center in partnership with Drexel University and Family Practice and Counseling Network, where she also provides pro bono physical therapy services 2 days a week. So we are so excited and can't wait for your presentation. So let me stop sharing my screen and make space for our presenters to share their screen.
All right, can everybody see that? Can folks see the slide? Yes. Awesome, welcome, good evening, everybody, if you're in Eastern Standard Time Zone. Welcome to the presentation, An Integrative Health Approach to Support Emerging Adults Impacted by Violence. So we want to just lay out for you all today or all this evening how our presentation is going to go. So first, of course, we're going to do introductions. We'll lay out our objectives for the presentation, which you should already have or have already seen. We'll define some terms so that everyone is on the same or has at least a good fundamental understanding of the language that we're using as we progress through the presentation. And then it's important to talk about our clinical space. And as we go on, Dr. Wenger and I will say more about the space that we work in together. And then the biggest part and most important part of our presentation is the case study that was co-created based off of work that we've done with clients that you'll get a chance to go through as we're talking through it to kind of do some reflection and think about how you might work with the client that we are presenting to you. Then we'll move to outcomes and implications. And finally, we'll give you some tools that hopefully you'll be able to implement into practice. And so I'll start, and then I'm going to ask my colleague to unmute to do her introduction as well. There is an addendum to my bio. So I am no longer the program director of the Addictions Counseling Program. Currently, I'm the interim director of the same center, the same clinical space that Dr. Wenger is the research and academic coordinator for, and works pro bono, providing elite physical therapy services to the community. And yes, my clinical background is in mental health counseling, so I am a licensed professional counselor, and the population that I work with most are Black adolescents, particularly in the Trenton area, but more broadly because I'm doing telehealth, I work with adolescents pretty much everywhere. I define adolescents as anyone between the ages of 12 and 24, 25, and I can talk about that later as well. And so I'll pass the mic. Oh, and I'm from Trenton, New Jersey. I always like to rep my city. So I'll pass the mic to Dr. Wenger.
Hi, everyone. I'm from Durham, North Carolina, and I've been a physical therapist for 25 years. I have mostly worked in an outpatient setting. Currently, I'm working in a pro bono setting. My previous setting was like some workers' comp, a lot of Medicaid. And I've also bounced around. I've worked a little in home care and a little in acute care. So I've been in a bunch of different settings. I have my sort of specialty area is around complexity and chronicity and particularly chronic pain. So I tend to treat a lot of people who have, I always say, if there's, if you have more than one problem, I'm your gal, right? So if you have a lot of different things going on, that's where I consider my specialty to be. And yeah, it's been a pleasure to work with Dr. White at 11th Street, and I'm really looking forward to this presentation.
Absolutely. Before we continue and move to our objectives, and because I know Dr. Wenger, I know she doesn't have a problem with this, I do want to acknowledge that where Sarah and I reside and where we work and teach, it is Lenape land. And so we want to honor the people, the original people who were here on this land. And in honoring that, we're honoring the oppressive practices and the history of colonialism that strips people of their agency, of their land, and of their culture. In addition to that, it is February 7th, which means that we are in the 7th day of Black History Month, and hopefully everyone's doing something to celebrate the accomplishments, the peaks of the African-American community, Black community that have contributed so much to our society nationally and globally. Do you want me to do this or?
Go for it.
All right. So our objectives for the day, which again, I said you should have, we certainly want to amplify interprofessional collaboration. It's not a new thing. People have been doing it a long time. But however, in the helping professions, unfortunately, people still work in silos. And so we want to promote and talk about interprofessional collaboration and how we use it as a tool to facilitate self-efficacy. We'll demonstrate the relationship between PT, physical therapy, and mental health counseling in supporting our patient-client wellness within under-resourced communities. We use patient and client interchangeably because for Dr. Wenger, I believe she uses patient, and as a mental health therapist, as the social workers are known here, we typically use the language of client, and we want to honor both. We already said that we would provide you a case study, and so we'll formulate a unified plan of care that centers the patient's needs, community, and culture, and apply principles of anti-racism and trauma-informed care. How we use it in an integrated health setting, and then also we will weave that throughout the presentation because it's at the core of what we do, going back up to that first bullet point of shared values.
So defining terms, we're just going to define a couple of terms so we're all on the same page. We're defining interprofessional collaboration with the WHO definition, the World Health Organization, as collaborative practice that happens when multiple health workers from different professional backgrounds work together with patients, families, carers, and communities to deliver the highest quality care across settings. And we're going to talk about this really threaded through the talk. We're defining self-efficacy as the American Psychological Association defines it, an individual's belief in his or her capacity to execute behaviors necessary to produce specific performance attainments.
Also, in that under-resourced community, this is a term that I actually started using years ago, and it's, has permeated the cultural zeitgeist of our profession. So that's a great thing. But it's when we're talking about communities that have high rates of poverty and low-income households where access to a variety of quality care is either limited or non-existent. The reason we use the term is to place the onus of responsibility on society versus individuals and communities. A thing happens when you call people poor or impoverished, that labeling impacts how we see them and how we care for them. And we tend to make them responsible for their own victimization. And so it's important that we speak to how redlining has impacted communities, how institutional racism has impacted communities. And so there are communities that are under-resourced very intentionally of no fault of their own. So we choose to use that term instead of, impoverished communities or, communities living in poverty. So this is the term we choose. Anti-racism, and we're using Ibram Kendi's definition, a powerful collection of anti-racist policies that lead to racial equity and are substantiated by anti-racist ideas. And so that is important because a lot of folks deem themselves anti-racist, but it's something that you can't just be, it's something that you have to advocate for in policy and actually put into practice in writing, right? Because we want to make sure that you have something to hold people accountable to and something to hold yourself accountable to as well. And then finally, trauma-informed, and you all will be able to get these slides. There are hyperlinks throughout the slides that take you to resources. And I want to shout out Dr. Wenger for doing that heavy lift. But a strength-based approach to service delivery and organizational structure, grounded in an understanding of and responsive to the widespread impact of trauma, including historical and identity-based trauma. And so we recognize trauma not just as the typical traumas that occur, such as assaults or witnessing the death of someone, but we also look at how racism, and that's what it means to be, these things tie into one another, how racism and other forms of oppression have resulted in trauma for many communities. With trauma-informed care, we take into consideration the possibility of trauma in a patient's history, in all our patients' history. And instead of asking what's wrong with you, we ask what happened to you. And we don't literally say those words, what happened to you, but we approach the client or patient from that stature, or from that posture, excuse me. And so I'm going to allow Dr. Wenger to talk more, and I'll chime in here and there because Dr. Wenger has been at 11th Street for over 15 years. I know I always undercount, and so I'll let you talk about it.
Okay, 15 is right. So 11th Street is a collaboration between a federally qualified health center, family practice and counseling network, and Drexel University. It's a nurse-led integrative health center. We have primary care, dental, physical therapy, every flavor of behavioral health you can imagine, mind, body, social work, creative arts therapies, nutrition, and all kinds of different classes and community outreach. We have a community advisory committee that's been with us from before we were us, from the very beginning, and have been consulted and had input on every step of our development. And we use a sanctuary model. So that's a model for trauma-informed care. It's not the only model for trauma-informed care, but we are sanctuary certified. And that's the model we use to keep trauma-informed care integrated into the way we treat patients, but also the way that we sort of administer ourselves and conduct ourselves in the center and interact with each other. We have training and onboarding both for new employees and for any students who are going to be in the center that gives them at least a little bit of a background in trauma-informed care and anti-racism, and goes over the history of 11th Street and really invites them to share in our values when they're onboarding. And we have a commitment to anti-racism that really permeates everything that we do in the building. You want to add to that?
Sure, that was super concise. Absolutely. Yes. And so just so folks, I just want to reiterate a couple of things that Dr. Wenger said in regards to the sanctuary model. One of the things I love about 11th Street is we don't just approach our community members, we are all a part of the community. And so we try to live or embody trauma-informed care, even in our interactions with one another. And the way that looks, or some of the ways that looks, is that at the top of all of our meetings, we do really extensive check-ins. We do a grounding mindfulness exercise. We have coping cards, and we check in with each other. If we feel like something's going on, whether there's conflict between folks on staff or there's issues with a patient or client, we do SOS meetings and we call everybody to the table. And so we really try to embody that. The training and onboarding was largely developed by Dr. Wenger because in her role, she believed that anyone who steps foot into the door have to have a fundamental understanding of what our culture is and what it means to be trauma-informed and what it means to embody anti-racism, particularly because we work in a community of predominantly Black folks who have complex needs and complex trauma. And so I just wanted to add that. And you said something earlier that I wanted to speak to. Dr. Wenger said we have a community advisory committee that's been a part of 11th Street before there was an 11th Street. And to me, that's super unique. And if you want to speak more to that, I invite you to chime in, but 11th Street came to exist because it was something that the community wanted. There was a community assessment done by nurses, public health nurses, and what came out of there is that they wanted a health center that was accessible, where they could receive quality care, confidential care for them. And because they wanted it, we were able, or, you know, the group at the time were able to get the money necessary to respond to the need. And so that community advisory committee really push forth this effort to get the center right in the heart of their community. And a lot of the things that we do now at the center is in response to the community's wants or needs. Did I miss anything, Dr. Wenger?
I think that covers it. We have meetings every month, and we really do run by, like, if somebody wants to do research, it has to be approved by the Community Advisory Council. We run by, like, our programming. We don't just put programming in. We go to the Community Advisory Council to see what kind of programming they're interested in. And we really try to, you know, work with, not on.
I love that. All right, that's a good segue. So more about us. And so, and at the top of the presentation, I said there were some things that we're going to be talking about that we want you to reflect and engage in some introspection around. And this is one of those spaces. So as we talk about us and our approach, particularly for the students who are emerging professionals, I want you to think about what your approach is going to be to community-based practice. And so for me, there are many different communities. And so I say this with that understanding, but I see myself as a IMIC scholar practitioner. And so what does that mean? It means that the very communities that I choose to work with, the very communities that I do research with, are communities very similar, if not the same community that I come from, right? And so I decided to pursue advanced education because I didn't like what was happening within my community. And so once I got my bachelor's degree and I started working, I said, oh, okay, I need a master's degree because I want to be licensed to be able to be a provider. Because at that time in my city, I told you I was from Trenton, New Jersey, at that time there was only one therapist located, one Black therapist located within the city. So then I got my license and, you know, I was in school and going to meetings and joined organizations. And I was like, these policies suck, right? And so what can I do to get, you know, policy changed and get people to see how best, you know, get community members' voices and scholarship so people can see how best to work with people who look like me and people who come from backgrounds like me. And so I remember my undergrad, one of my professors, she said to me, you should get a PhD. And at the time I was like, I'm not going back to school after this. I want to be done. And then after I got my master's working in the field, I said, you know what? I need to get a PhD because I felt like the voice of people who look like me, the voices of my friends, my family, my church community was largely missing from the research. And well-meaning people would come into the community and do more harm than good because they didn't understand the context. They didn't understand the culture. They didn't understand that some behaviors were necessary behaviors for survival in certain contexts, right? They didn't understand the value of interdependence and wanted folks to be independent, which really is harmful to certain communities. And so the way I approach community-based practice is authentically, right? I am myself 100% of the time, or I try to be myself 100% of the time. I try to be transparent with the community. And I love that Dr. Wenger used that phrase, work with instead of on. I want to make sure that I am responsive to the community. And the way I do that is by using things that are indigenous or integral to the culture of the people that I work with. I don't just pull from the textbooks that I learned from, the articles that I read, or from the lectures that were taught to me. I look and see what has been helpful, what are the strengths in this community, and how can we infuse those and use those in the care that we provide. And so thinking about my identities as a Black woman who grew up in an under-resourced community, primarily raised by my mother. I say primarily because a whole bunch of people raised me, are responsible for getting me to, you know, this point in life, and who is uniquely situated because I have that experience and also have the experience of having a PhD that completely influences the way I show up in every space that I'm in, because I feel like I get to amplify the voices of the community in the very rooms that they may not be invited into. And also when I'm with the community, I get to bring to them things that they may not have access to otherwise. And I will pass it to Dr. Wenger.
Yeah, so I have arrived at that same, these policies suck, and that same desire to be authentic and transparent, but via a completely different path. So I did not grow up in a community that was at all similar to the communities that I serve and work in. I think that it's not, I don't feel like I got out of school and was like, I'm going to go work in under-resourced communities. But I did feel the urge coming out of school to be of use and be useful. And I think that not necessarily, I think if I look back on, young me, I've been a physical therapist for 25 years. So if I go back 25 years and look at new grad Sarah and what she was thinking, I think I fell into it more than I thought my way into it. But I just always felt like, all these people are, fighting to treat the athletes and be the PT for the sports team and do that, like nobody's doing this over here. I'm just going to go over there and do what nobody's doing. And I just have always been like attracted to those paths because it's been, I think just inherently it's important to me to feel useful. And I feel like I can do, like, if there's 100 people over serving a place over here, well, why do I need to be there? I want to be somewhere where it's not happening, where I can really contribute. And I think that that series of decision making has very much led me to under-resourced populations. And it's also led me to underserved diagnoses like chronic pain and just complexity. I think those are both diagnoses that are very underserved. So I feel like my career path has sort of tracked me in that way. I certainly grew up resourced. I grew up in a very resourced community. I'm white, I'm Jewish. And, I went to private school. I had educated parents that helped me do homework and navigate higher education and all of those things. But I think I arrived at this idea of these policies suck really when I started. Well, I mean, there are lots of times sort of throughout my life where that was occurring to me, but really when I started working with underserved communities, just seeing like, I know what the standard of care is. I know what I was taught in school. And then somebody comes to me and describes a story that is just not that, it's just not the standard of care. And really realizing that while there's a lot of narratives around the people that I'm seeing and about, whatever, you can't help them unless they help themselves, or you can't, if they're not going to come, then what can we do to help them? But then really sitting down and talking to people and realizing, well, they can't come because transportation's a problem, or they have childcare issues. There's just all this stuff going on. And I don't know, I'm just a totally curious extrovert. So I ended up gathering those stories from people. And I'm kind of an empath, I guess. I've always been interested in people. And I think also with my background, I've had, even though I'm, white and well-resourced, I was pretty much the only my family were the only Jewish people we knew growing up. So that idea of sort of being different and not being like among my people, if you will, that is an experience that I have, that I feel. And so when other people tell me that that's how they're feeling, that's very understandable to me. And I had not a super, I wouldn't say like the school that I went to was particularly diverse, but I did have a lot of diverse influences growing up. My parents had, friends, across the socioeconomic spectrum. They had friends of, different colors and ethnicities. And so I did have some background to draw on, I think, that really helped me learn once I became a professional, and helped me, I had a little bit of a platform to work off of when I became a professional. And so I too arrived at this idea, like, what is going on? This is, this care, the quality of care just isn't what it should be. It's not what it's supposed to be. And if this person is struggling, it's because they don't have the resources they need. They don't have they're not getting the care they should be getting, and I'm seeing all of this. And that's really what sort of brought me to this idea of policies suck. So that's something I learned. And I have found too that just being really transparent and really authentic, because I don't know who else am I going to be, right? Has been really helpful to me, like as somebody who's other, somebody who's different, walking into a community and trying to really serve the community well when I don't have that personal, authentic experience. I think it's important to just show up and be yourself. You can't, I'm not going to pretend like I'm down or I understand, right? I don't have that experience. So just being authentic in myself, but also authentic in my curiosity and my genuine desire to help people out. I think that sums me up.
Yeah, and that's so important because I think, and I don't know, Dr. Wenger, you can speak to this in your profession, but particularly in the mental health professions, I feel like there is this exorcism of identity or divorcing of identity, especially for people who are racially minoritized, that you have to put something else on to be a professional. Like being a professional means this thing, but we can't separate ourselves from who we are. Right. And that means that who we are influences the work that we do. It influences the beliefs that we have around client behavior, patient behavior, why they make the decisions they do. Right. It's the difference between saying, oh, that client is resistant, or that client is fighting for their safety or fighting for autonomy. Right. And so how those things are different when we're speaking about clients. Because if I've already decided that a client is resistant, first of all, that's more based off of my stuff than that client stuff, right? Where is that coming from? Is natural apprehension just that natural, right? Do you go into a space and just open up your wounds and tell your full story right off the bat? Or in some communities, could that be very dangerous? And so thinking about those things, so I really appreciate how you said, go in this authentic space, knowing not just how we view people, but also how we are perceived and how that influences care as well. All right, and so this is the case study piece, and so if you want to take notes, feel free to do so. I know that there will be questions at the end, and so if you're like me, different things will take me in different places and I'll forget my original question. So write your questions down so that we can come to them at the end of the presentation. And so for this presentation today, E is a 19-year-old African-American cisgender male. He's a high school graduate who lives with his father and grandmother, and the grandmother is his paternal grandmother, so his father's mother. He grew up attending church, but he does not consider himself religious. 3 months prior to his first session, he was shot by a peer. And during the rehab process, he started to exhibit symptoms that would fit a diagnosis of depression.
And this is a clinical reasoning model for chronic pain that we had pre-existing at the center. And so this is something that we developed to describe interprofessional collaboration around chronic pain care. And this E had chronic pain related to his gunshot wound. So I'm just going to go over what this model shows. And then at the end, we'll sort of review it again and point out, how we did it. So if you look at the top of the screen with that white sun shape, that is representing a self-managing patient. So this is really a model that kind of works for chronic pain, but it also works for any kind of chronic problem. So if a patient has a problem, or client has a problem that's not going to go away, it's chronic, and we're not going to make it 100% better, then our focus, our goal of care has to be that patient can manage themselves, manage their pain, manage their quality of life, learn how to thrive in the space of having this chronic illness or this chronic pain in this case, and that they really are empowered to manage themselves. Not to say that they're doing it alone. The healthcare, the healthcare team is there, not as like, I'm your provider, you're going to come to me and I'm going to tell you what to do, but we're there to educate and to support and really consult with the patient as they take care of themselves. So that's the sort of the ultimate goal of treatment. And you can see that sun is kind of shining rays down on the rest of the model. And the idea is that that ultimate goal is what is informing everything else that we do as a team. In the middle, you see a bar. It has some professions listed. It's certainly not all inclusive, but this is whoever's going to be on your interprofessional team. And please note that the first person on that interprofessional team is the patient, right? So the patient and family and any other stakeholders would be included in that team. And the idea of the team here isn't merely that we have a bunch of different people in on the game. The idea is that those people are coordinating and communicating with each other to create goals that are unified, to engage with reasoning with each other. So like as we're all doing our clinical reasoning and reasoning through what's going on, that we're explaining that to the patient and explaining that to each other and sort of letting everybody else's reasoning influence ours, so that we end up, all of us, including the patient, with this one concept of reasoning about what's going on. And that helps us arrive at unified goals and a unified plan of care. I think what happens with patients or clients a lot is that they see, 5 different professionals and they're given 5 different pieces of advice and 5 different treatment plans, and it's just overwhelming. And they don't know like which of these things is important. How do I prioritize it? Like what's going on? And I've seen so many patients that come to me and they're just completely confused and overwhelmed about what they're actually supposed to be doing. So I think this idea of a unified plan of care where the patient has like a plan of care that feels like one thing, even though it's made up of a bunch of different professionals' perspectives, I think that's really important. And then these pillars at the bottom are just representing different areas of evidence. So Dr. White might have a degree in mental health and know a lot about that pillar, and I might know more about, movement and neuroscience and epigenetics, a little bit on the epigenetics. But both of us, if we're going to treat somebody with chronic pain, both of us need to have some understanding in all of these different pillars, so that we can communicate with each other and understand and make that unification happen. And if you look all the way to the right, you'll see patient characteristics is a pillar. So that's really like, I always tell my patients, you can put however many initials you want after my name and you can make me as smart as you want to be. Like, I don't know what's going on inside of you. I don't know what's going on at home. I don't know what's pulling you in this direction and that direction. So really honoring the patient as this, objective source of information about what's going on with them. And I think that in healthcare a lot, certainly on the physical side of healthcare, we tend to value things we can measure. And I think that the subjective, I hate even calling it subjective. I think the objective information that our patients giving us that we call subjective is really undervalued. And so this is just making sure that we understand that information we're getting from our patient is also evidence that informs our decision making. So using that plan of care, that's what we use to sort of frame out how we approached E. So I'm going to talk a little bit about just how E entered the healthcare system, the healthcare system and his injury. So the gunshot wound was to his left foot. He had a pretty complex fracture. So it wasn't just like 2 pieces, there were multiple pieces of bone. And when there's a lot of pieces of bone like that, you can't just put it in a cast or do the kind of normal surgery because it's in too many pieces and there's too much swelling. So they put what's called an external fixator, which is kind of like a halo that goes around the foot, and it has like pins that come in. So it stabilizes the fracture, but you aren't actually opening it up. So he had to have that on for a while, which means he can't put weight on it. He's definitely on crutches. It's this big thing to lug around. It's pretty heavy. So you had to have that on for a while. And then once the swelling went down and healing had started a little, those little pieces of bone and started to heal together a little bit, then they did what we usually think of with surgery, where they opened it up and put like plates and screws in. So an ORIF is an open reduction and internal fixation. So they went in with plates and screws and did sort of a normal fracture repair. 17 months later, he got an infection, and that really set him back. And so with an infection, he'd be back to not being able to put weight on it. It's painful. It's scary because it threatens, the healing am I going to heal? What's going on with the fracture? And 2 months after that, they went inside. And so they had another surgery where they took out the plates and screws. They took out the hardware because it can be very hard to heal from an infection with metal in there. Infections like metal. So they removed the hardware, and he was able to heal from that infection. But now he's had the gunshot wound, an external fixator placed, the original surgery, and surgery to remove. So that's 4 traumas all to his left foot, spanning a pretty long period of time. I mean, we're getting on to 19, that's 19 months of time. So that's a long time to not be able to function, and just multiple traumas, physical traumas to that ankle. The medications he was on was oxycodone, which is an opioid, gabapentin, which is a medicine that we give to people who have nerve pain, and naproxen, which is an anti-inflammatory. So mobility wise, because that's what I do in PT, is sort of assess people's mobility. He walks with a limp. He can walk or stand for about 10 minutes. And after that, his pain gets bad and he feels like he needs to sit down and rest, elevate his leg. It really starts to hurt. His balance is pretty poor on that side, as you might imagine. So his balance is, typical young man on the right, but pretty poor on the left. He's got significant weakness throughout his ankle because, of course, after 19 months of not being able to walk on it properly, it's gotten very weak, and his calf is particularly weak. It's like visibly very, very skinny. That's what atrophy means, just very, very skinny calf. He used to run and play basketball, and he absolutely cannot do that. He's also used to work as a chef, and he's unable to work as a chef. So that's sort of how he presented into the system. What our plan was in physical therapy to address like mobility issues and sort of some of the physical things he was coming in was obviously to do strengthening, especially of that left calf, to help him with gait training. So help him learn how to walk. So he's walking with less of a limp and could walk a little bit further. Doing some cardiovascular exercise. I think this is a super important point, because when you get injured, even if you're this young, healthy guy, you get injured and you're on crutches and you can't walk, well, you can't exercise, and you're going to get out of shape. And we know that being fit helps all body systems work better. So it's not just, we're not just fit so we can be muscular and skinny, right? We're fit so our body systems work. And we also know that it impacts mental health, right? It impacts depression, anxiety, and a whole host of other mental health things. So he really hasn't been able to keep up with fitness. So finding some kind of way where he could get some kind of cardio in where it didn't bother his ankle was a really important part of our plan of care. We knew now that he's been on opioids for quite a while now, since his original injury. So, we don't want to, the longer you're on opioids, the more risk you have of all of the bad side effects, and the less it tends to be actually effective at pain management. So opioids really great at acute pain management, not a fabulous tool for chronic pain management. And we're really merging into that chronic space. So we know we need to think about how to taper him. When you approach somebody who's in pain and say, hi, we want to give you less pain meds, that is totally illogical, right? It doesn't make any sense. I'm in pain, but I shouldn't take pain meds. Like, it doesn't make any logical sense. And it's scary, right? It's scary, especially if, E was like, I'm in pain on the pain meds. Like, I can't even imagine how bad this pain will be off the pain meds, right? So it's scary. So what we do, and the way that we typically approach that, or the way that we should typically approach that, is really with a lot of education around pain and what generates pain, what contributes to pain, what are our opportunities other than opioids for managing pain, and really trying to give him some information about, like, yes, as we taper these things, but there are other tools that you can use that will replace those, that will be more effective in the long run. So we did initiate at the beginning some education around that. And then just, this is not something I discussed with E at the beginning of care, but certainly noticed some interplay between pain and mental health. We know that mental health and pain are very intricately related. I certainly noticed a lot of fear and reluctance. You know, if I mentioned weaning off opioids, you know, that definitely brought up some, what I perceived to be anxiety or fear. He was very reluctant to engage in a discussion with me about it. And I felt like, you know, he would benefit. He also had a gunshot wound and 4 surgeries and was this young guy that couldn't move. I mean, there's so many reasons for him to not be feeling great about things. He'd had this long 19 months of surgeries and not moving and everything going on. And I just felt like he would benefit from the support of mental health. And so I really, you know, wanted to make that suggestion to him. And, you know, I do this a lot in my practice. And sometimes I think there's a way to do that that's really inviting and engaging and kind of destigmatizing. But I think it takes a lot of skill, because I think people go immediately to stigmatization. You know, as soon as you recommend a mental health, there's like, what are you saying? I'm crazy. Or, oh, this, you're just telling me the pain's, I'm making it up, or the pain's only in my head. So as I'm making those referrals, I'm really saying things like, you know, a lot of people who have had these, you know, long and difficult experiences like you have, or a lot of people that are experiencing chronic pain and, you know, can't work and can't do the things you want to do. So many of my previous patients have really benefited from seeing a mental health provider. I think it will help me be a better physical therapist if I collaborate with a mental health provider. It's something that I've seen really be beneficial for lots of people. And, you know, you have had pain and all this stuff going on, like that has to be stressful. And I think if there's support available for you, you know, why not take advantage of the support that's available to you? Because this is certainly a difficult time. So that's the kind of thing I would typically say as I'm making a referral.
All right. And I just want to add something else that Dr. Wenger does in a physical therapy space at 11th Street is when people come into, and I mean the staff that work there, when we walk into the space, she lights up. First of all, she's like, hey, and then she'll say, hey, do you all know this person? She's a creative arts therapist, or this person, she does meditation and yoga. This person, they do dance movement therapy. And so she's constantly talking about the other services in the center. And because we're such a collaborative space, people are always walking in and out of Dr. Wenger's space. And so people get to see our faces. And I think that's another reason why referrals have been more of an easier process, because people are familiar with the community inside the building. And so now E's referred to me. And the way that E presents to me is open and engaged. And so I want to break that down, and I want to encourage those who are going to be seeing clients when you become a provider, what you write down in your notes matter, right? Particularly when other people are seeing them, particularly if you have mandated clients, right? All of those things matter. And just because a client may not be answering the questions you want them to answer, it doesn't mean that they're not open and engaged. And so when I say that he was open and engaged, he was very open, talking about that he enjoyed playing basketball and things of that nature, and, you know, how his physical therapy has been going with Dr. Wenger. And so making sure you're approaching things from a very strengths-based posture. So he reported decreased enjoyment in previously pleasurable activities. When he's not seeking work, he mostly remains in the house. Recently lost 10 pounds, I'll go through all these and I'll come back up. Reported difficulty sleeping, exhibits avoidant behavior, has high levels of hypervigilance, extremely apprehensive to discontinue meds. You know, Dr. Wenger was just talking about, you tell someone who's in pain, stop taking pain meds. It's like, wait, what? So this apprehensiveness presents as reluctance to taper. And there's also, quite obviously, even though he hasn't said the words he's afraid of the pain, it's pretty obvious that he's afraid of the pain. He reports becoming agitated, irritable easily. And something that he said in session is, I just don't really feel like being bothered. And so for those of you who are familiar with the DSM, which is the Diagnostic and Statistical Manual, it's the criteria we use to diagnose for mental health disorders, I'll say, dis-orders. When you look at these things, you might already be thinking about the diagnoses he might meet the criteria for. And I know that we talk about this later, but I'm going to skip ahead and talk about it in more detail when we get to that slide. But some of these things are on the borderline, right? And so when you see recently lost 10 pounds, yes, that could be a sign that his appetite has decreased. Yes, absolutely. Or it could be, people lose 10 pounds is a lot of weight, especially if he's a, larger male. 10 pounds may or may not be a lot of weight. But think about how Dr. Wenger talked about him not being able to exercise or move for almost 2 years, right? Think about, he has this big apparatus, I'll call it, I may be misspeaking, Dr. Wenger, but this big apparatus around his foot. And so he's someone who has been largely sedentary, but still recently lost 10 pounds. And so typically, if you think about it, if you're sedentary, it's more likely you'll gain weight than lose weight. So thinking about that. Another thing I want to point out, which again, we'll talk about in more detail on another slide, is high levels of hypervigilance. So what does that mean? Someone who's really cautious, constantly looking over their shoulder, suspicious of people. And we know that hypervigilance is one of the main characteristics of anxiety and PTSD, right? Which is post-traumatic stress disorder. And so folks might say he would certainly meet the criteria for that diagnosis. However, consider that he's here for a gunshot wound, right? Certainly, sure, it could be PTSD, but how also is hypervigilance maybe serving him, considering the context in which he finds himself? Also, it's important to look at the decreased enjoyment in previously pleasurable activities. And so, yes, as a therapist, this is why I say we have to be really careful about how we write things. As a therapist, I can write down, yes, he reports that he has decreased enjoyment in previously pleasurable activities. But as someone who is collaborative, maybe it's not that he doesn't enjoy it, maybe it's just that he can't do it. So if he could do it, he might enjoy it. So would that be accurate to write down? Because that will be seen as a significant symptom. And so I just want folks to be mindful when you are working with clients, particularly clients in under-resourced communities, particularly clients who have been greatly stigmatized due to the history of racism in our country. We have a Black male who has a gunshot wound. Think about all the assumptions that providers are going to make about this individual, and how when you see these things on paper, the assumptions we make based off of that as well. Did you want to add anything here, Dr. Wenger?
Yeah, I will. So in terms of assumptions, so, I was not the first provider that he saw. He went to the ER, he had surgery, he'd seen a zillion providers before he got to me. And I felt like, he presented to me, like, I just felt like he wanted me to take care of him. Like he just had this kind of like, please take care of me kind of vibe to him. And my read on that was that, he didn't feel like he was well heard or well cared for prior to coming. And I really felt like he didn't expect to get good healthcare. And he didn't expect to get caring healthcare, like put the care back in healthcare. But that was just my read. So I think I really echo what you're saying.
Absolutely. And even that, and folks are really getting a glimpse into how we actually work together, because now we're just going back and forth. But even with that, that's one of the reasons why I also don't like, I hate all the R words, I think, resilience and resistance. I really don't like when people put clients are resistant, because given he had went to provider after provider after provider, by the time he gets to me, if he's not expecting good healthcare, why would he be open? Right. But yet when we phrase things and write things, we're putting all of this burden on the client. Like, you know, if you really want, like you said, if you really want to get better, you'll make the effort to get better, not looking at this person's history of interactions and how that may influence the way they're interacting with me today. So thank you for that.
And I'll add one other thing about the weight loss, just from like a total PT perspective. You know, if I'm looking at a young, healthy guy, you know, whatever, young people don't gain weight, you know, they're just young and healthy all the time. So like, even though he's had a decrease in activity, it's not, I mean, it can happen obviously, but it's not uncommon for a young person to maintain their weight. So when I see that weight loss, I think muscle mass. You know, he's not working, he's not doing stuff. It's totally feasible that from going to playing basketball to not playing basketball, that he's lost 10 pounds worth of muscle. I know he's lost a couple pounds worth of muscle in his calf because it's like a third of the size of the other one. So that's where my mind would go in terms of thinking about possible explanations for that.
And hopefully folks are starting to see, if you hadn't already, the benefit of interprofessional collaboration, because that right there, as a mental health provider, especially if I'm a new mental health provider, I'm like, oh, recently lost 10 pounds, that's a red flag. If I'm working with the PT who says, well, he can't move, and so losing muscle mass is completely common, you can see it, then I look at that very differently, right? And maybe that's a symptom now that I remove when I'm thinking about a mental health diagnosis. So hopefully folks are beginning to see like how important interprofessional collaboration is. All right, so assessment and diagnoses. And so before I go into this, I should probably say my background, the theory that I use most or subscribe to most is reality therapy, which is based off of choice theory. And there are a lot of critics of it, which is completely fine. We can have another discussion about that at another time. But I'm someone that leans more to never diagnosing anybody. And there's many reasons I do that, but primarily because the population that I work with, they've been labeled enough. And so I want to see them as individuals within a context, right? Also, we have to be reminded that racism is woven into the fabric of all of our systems, including healthcare, and that a lot of our diagnoses are inherently racist as well. And a lot of symptoms of depression and anxiety that present in African Americans aren't things that are listed in the DSM. And so that's important to know. However, if we're thinking about assessment and diagnosis, given the information that I provided on the slide prior, we're thinking probably these three things: depression, anxiety, post-traumatic stress disorder. So that's one option to look at. The second option I'm thinking about when I'm looking at E is good survival skills. So Dr. Wenger already explained that he walks with a limp and he was shot within his community. And so that means that, if I can use your words, Dr. Wenger, he is visibly a target. And so if he's visibly a target, it makes sense that he's suspicious, that he's that he's hyper vigilant, that he's cautious of his surroundings, that he's not as open, that he's isolating in the home, right? I wouldn't be going out a lot too if I felt like my mobility could compromise my safety. And along with that is oppression. And so when we were talking about being anti-racist and trauma-informed, that means that we're not just looking at the day-to-day experience that our clients have, but also the historical influence that shows up in the day-to-day experiences of our clients, right? And so oppression to me is the most frequent diagnosis I see in the clients that I serve. That they are figuring out ways, and some have, to healthily and adaptively navigate oppressive circumstances. One of my favorite psychologists, Dr. Thomas Parham, he always says that an abnormal response to an abnormal situation is a normal response. Oftentimes in our fields, though, we're focusing on these abnormal responses and not looking at the abnormal situations. There's no way to respond normally in an abnormal circumstance. And then that leads me to the third bullet point. If you're not aware of the community, of the context that your clients are, that they live in, the backgrounds that they come from, there is a huge danger in misdiagnosing or overdiagnosing. I was sharing with Dr. Wenger when we were putting this together, I can't tell you how many clients come to me with pages and pages of diagnosis. One therapist says this, one therapist said that, one psychologist, one psychiatrist, I mean, all over the place. Now that can mean a lot of things. Clearly there's an issue in our in our mental health system if all these educated providers see different things, right? Or we can say that there is an issue with our diagnostic system, particularly when we're working with patients who have complex needs, complex stories, complex traumas, and their lives are situated in these oppressive spaces. And so if I'm diagnosing, I always diagnose with the least harmful diagnosis. And what does that mean? If I don't need to diagnose, I don't. But if for insurance purposes I do, then I put what would be least harmful and still sort of accurate. I'll say that. I know this is being recorded, so I'll say that and leave it there. And so for the treatment plan, some things that we need to consider as providers. How much time do we have with our clients, right? And so given people's theoretical orientation, like some folks are really into psychodynamic and existential therapy, listen, folks may not be with you for years and years and years, right? You may have very limited time. And sometimes you may have to treat each session as a one at a time session, knowing that, okay, maybe the client may not return. And so I explicitly ask my client, you know, how much time do we have together? Or do you think it's realistic for us to work together? I ask the client, what do you see as your strengths? And I always start there. I rarely say, what are your weaknesses? But I always say, what are your strengths? And when I'm working, when parents bring their minor adolescents to me, I have the parents or guardians, I say, name 10 things that's great about your child or great about your niece or, you know, whoever name 10. I start right off the bat. And right there as an aside, me doing that, sometimes the child or the parent starts crying right just from that question. Because they'll say, you are the first person that asked me what was good about my child. Right? And so that's important to be strengths-based. We don't ask, what's wrong with you? Right? We say, wow, you've survived so much and you're still here given all that has happened to you in your life. And then what would you like to see change? Another place that we mess up as mental health providers is that we have our own agenda for our clients. We feel like we know best what would serve our clients, or, and I do supervision as well with counselors or new counselors and counselors in training. They'll say something like, you know, but they could do so much more. They have so much potential. And I'm like, wow, there's so much judgment inherent in that statement, right? So much more for who? Right. And so we have to ask, so what is success for you in this space? And how do you see our work together? And then I always ask what barriers might exist in this therapeutic relationship. Now, I may not use those exact words, but I'm very, very explicit, particularly if I'm working in cross-racial dynamics, right? Or visibly different dynamics. So I can say, listen, you're male, I'm a cisgender woman. How do you think that might show up in this relationship? Do you have any concerns there? Right? Or I'm Black, you're Asian, what are what are some barriers you think might exist that might prevent us from doing good work together? What questions do you have for me that can maybe make you feel more safe in this space? My theoretical frame, I combine strategies and frame. My theoretical frame, like I said, I use reality therapy, and I know that there are critics of the model, but through an Afrocentric lens. And we don't have enough time tonight for me to go into detail about what that looks like, but I do culture-based therapy, really using strategies that are rooted in reality therapy and choice theory. And why is that important? The populations that I work with have been disenfranchised, disempowered, oppressed, marginalized. And I find that showing them that they still have agency makes the world a difference. That you don't have access to all the choices that everybody may have, but you do have choices. You do get to decide, and you do play a part and a role in your own life. And how can I help you along on that journey? And through my Afrocentric lens, spirituality is at the center. I have to center it. And I feel like people know now that spirituality and religion aren't the same thing, that religion can be a way that you express your spirituality, but just because you're talking about or expressing your spirituality, it doesn't make you a religious person, even if you do it religiously, right? But we have to center spirituality. And in our field, there has really been an exorcism of the spirit, which is super damaging, particularly to Black populations in the US. Identify and nurture relationships. One of the key components of reality therapy is finding and nurturing satisfying, healthy relationships. So one that is reciprocal, where the person feels like they're giving and receiving in that relationship. And sometimes in reality therapy, if the person doesn't have that, you are it for that person until you're able to help them find it, or help them find it on their own. But most of the time, there are already relationships in that person's life that are nurturing, or that could be nurturing with some support. Emphasize own power, right? And so with E, someone who has in some ways expressed fear about tapering and fear of the pain, I would simply ask questions like, okay, before this, have you experienced pain before? How'd you get through that? What did you do, right? And E might say, I sprained my ankle and still played a game of pickup basketball, right? Oh, okay. So you are able to take an amount of pain and still, you've proven that to yourself, right? So you've done it before. What's in the way of you doing it again? And let's talk through that. So showing examples of when it worked, like when E was able to use his own power. And of course, identify a plan, advocacy, and action skills. And so through an Afrocentric lens, it's important that clients not just know they have power, but become comfortable advocating for themselves. Our healthcare system will beat you down, right? Think about, calling your insurance company and waiting on hold, or trying to get paperwork from a doctor's office or a referral from here. And so working with the client / patient to be able to say, you know what, if you do this, you might get a faster answer. Or would you like me to write a letter and reach out to somebody? Or, if you ask your provider this, I know this, or I know another number that you can call, or another way, like showing different options that are available to the client, so that now they're not only making a change in their own lives, but they may be making a change in their friends and family lives. Because what happens when you work in a community? Once you give someone information, they tend to share that information with someone else. And then collaboration with providers is super important. I don't just go through this process with E. I make sure that E knows, and Dr. Wenger makes sure E knows, listen, since you're working with this provider, is it okay that we communicate with each other? What is okay to communicate? What is not okay to communicate? And so as I'm working with E, I then call Sarah, or walk right upstairs or down the hall, say, hey, when you have a minute, can we talk? Or say, hey, I have a minute now. And I say, hey, I met with E, and he mentioned that, you know, sometimes he's being pushed and he feels like he's not being believed, that he can't do another, or he can't stand longer, or he can't, you know what I mean? Or he's doing what you say he's doing, but he's in a lot of pain and he's afraid to tell you because he don't want to disappoint you, right? So I can come back to Sarah and say, you know what? Next time I found that this helped in session to get this out of him. Next time, try using this type of language, or say this, or bring this up, or bring, you know, some Swedish fish to your, you know, I noticed in my candy jar, he always goes for the Swedish fish. You might want to have that on hand, because even something as simple as that, he'll say, oh, you thought about me. You knew I was coming. You were waiting for me, and I feel cared for in that moment. And so I'm collaborating, I'm communicating with Dr. Wenger. What I'm saying, she's communicating back to me. And the patient is at the center of the work that we're doing. We're not doing things saying, oh, I did a good job as a therapist, you know, I did a good job as a PT. We want to make sure that we're working together to support E and his success.
And I'll comment there a little bit too, because like as someone who's not trained as a mental health provider, but is interacting with people all the time with various struggles, right, and various stressors, you know, I have this agenda to make somebody stronger, make them walk better, make them do things, right, or help them do things. But oftentimes there are barriers to that have to do with, you know, psychosocial, stress related, you know, with a whole host of things. And, you know, I'm not that person's therapist, right? I mean, I'm their physical therapist. I'm not their mental health therapist. So they don't have to tell me that. It's not really my place to ask. Like, I'm not there asking the kinds of questions that Dr. White is asking. And so there's just some information that I'm not necessarily going to have access to, that because it's not my skill set to dig into. So I have patients who choose to share things like that with me, but I also have patients who don't talk that much. And E was somebody who didn't. I mean, I could get a sense for things with him, but he's not someone, he did not talk about the circumstances of his gunshot wound. He did not talk about how he felt. He didn't talk about being afraid walking around. I could sense those things a little bit, but those were not things he chose to discuss with me. And so having someone who has discussed, you know, where he's at, how he's feeling, come back and give me some feedback about how best to support him and how best to help him progress and, you know, meet his goals in PT is just so valuable. It's so helpful for me to have that interaction and for me to get those little like tips and tools to help create like a more comfortable and more safe environment without me having to sort of violate privacy by asking, you know, him to unpack things for me that I'm not trained to sit with. Yeah.
Absolutely. And something that's important when you're working right in the community, you just made me think of this, Dr. Wenger. Like sometimes it's as simple as, hey, Sarah, when you're working with him, can you try to not use any language that speaks to how weak he is? Because he was saying that he knew one of the gentlemen in the gym, and when you said that, he felt like that made him a target, right? So there are actual life-saving things that we can share with one another to help a client's treatment and progress. So you made me think about that.
Yep. So we were also coordinating with, E was seeing a physician assistant as his primary care at his primary care office. And so we were also coordinating with him to sort of tackle how we did this taper. So the taper started, you know, basically 2 years after the gunshot wound. As we've already discussed, he was really concerned that not only that initiating a taper would create pain, but also that he would be, you know, limp more and have less function. So he was scared about both those things. And he expressed concern to me about both those things. He was taking, so we're just talking about the oxycodone here. We left the gabapentin and the Proxen alone because they're not particularly harmful on a long-term basis. I mean, they can be, but definitely not as concerning. So we're really focused on the oxycodone, which is the opioid. So he was taking it 3 times a day. The initial plan from the PA, the physician assistant, was to get him from 3 times a day down to 2 times a day. Now, one of the unfortunate things about tapering from opioids is there is almost always an initial spike in pain. There is also almost always a return to baseline if you stick it out. But if you're worried that tapering is going to create pain and then boom, there's that spike, it is very hard to stick it out and wait for it to like gradually come back down, which is what typically happens. So he had this increase in pain and paused the taper. In my talking with him, so I knew that because I'm seeing him regularly, right? The PA is only seeing him like once every month or 2 to monitor. I'm seeing him a couple days a week. So I know that what's happened when he's done it the 2 times a day is that 1 dose is wearing off and he's getting a lot of pain and he's in this terrible pain before he takes the next dose. So I thought, well, instead of doing twice a day, why don't we keep it at 3 times a day, but do half a pill? So at least he has coverage all through the day. And so we were trying to do that, but he really he felt like I need the pain in my ankle to go away before I stop taking the pain meds. So like we can do the therapy and we can do the rehab and we can get stronger. And when all that, works and cures me, that's when I'll stop the taking the medication. And so we had a lot of discussions around, letting him know, when we first start tapering, it always spikes, but it does usually return to baseline. So setting some expectations. You certainly wouldn't want to start somebody on a taper and not tell them that, right? Because then it's going to be a not fun surprise, right? So making sure that he knew what to expect and he knew what we were expecting. And then also to have some discussion around, you had a gunshot wound, another surgery, the hardware removal, the ankle is, it's never going to be back to normal. It's never going to be exactly the same. That isn't to say that it won't be serviceable, functional, but that's the idea that it's going to be cured before you stop taking meds. We're not going to get to that point of cure. That's not realistically what's going to happen. We're going to get better and better and better until it's at a point where it's livable and acceptable. But that's really different than it's going to go back to the way it was before the gunshot wound, because that's probably not going to happen. So really talking about how as we strengthen and as we work on balance and as we normalize gait pattern and get his function better, so gait pattern's just walking, that we expect a joint, no matter how, damaged that joint is, we expect a joint that's supported by strong muscles, that is moving well, that has good balance. So there's not all this wibble wobble happening. It's moving nice and smoothly with good balance. It's moving in a more normal walking pattern. We expect those things to decrease pain, but we don't expect them to cure and make zero pain. So really setting some expectations around what to expect with the taper, what would be replacing that medicine in terms of helping with his pain, but also sort of talking about this idea of like, if you're going to wait for it to be cured, you're going to be on opioids forever. And that's going to come with problems. So also discussing what are the side effects of taking opioids, things like constipation, it affects mood. And over time, there's some evidence that opioids just are less and less effective at actually managing pain. So once that initial spike comes and you start tapering them, there's a spike, but then you usually get back to normal. And then often you can make progress that you couldn't make when you had the opioids on board. And so setting up all of that stuff. We did a lot of discussion and education around that. You can go to the next slide. Oh yeah, that's you. So we did a lot of discussion around that. And that's something, again, that I would communicate with Dr. White, like, hey, this is really stressful. Like, we are trying to do this taper. This is the kind of education we're giving. It's, stress and E out. Like it does not feel comfortable for him. It doesn't make sense to him. Like it's really hard, understandably, right? But it's hard for him to really engage in this treatment plan because it just doesn't add up and it doesn't make sense and it's scary as hell, right? And not just scary pain, but also really a lot of fear around losing function, and there's already a lot of concerns around function.
And so with E, we discussed feeling pain as an additional handicap. And so as Dr. Wenger was, talking about E's case, when E's in my session, he's saying, I have this limp, I have this thing around me. And then if I'm in pain, it's like, I really can't do anything. I already feel like I'm limited. And now I feel like I'm just contained if I'm in pain. And so the conversation around that was, how can I work? How can I, do all these things if I'm in pain? Okay, so I had the surgery, the device, but the pain is an additional handicap for me. Explored notions of suffering as well. Like, what does it mean to suffer, right? What's the difference between, when we have our conversations around racism and anti-racism at the center, we tell people, make sure you're distinguishing between safety and comfort, because a lot of time people mistake comfort for safety and say, oh, I don't feel safe. Having this conversation like, well, I mean, do you really not feel safe, or are you just uncomfortable? And so talking to E about, okay, what is pain? What is suffering, right? What is enduring? What is, working, like really talking about language and how much you can take. And so if you're in pain, what does that mean for you? Right? And so having those deep conversations. And so what would happen if you were in pain? And what would happen if that happened, right? Having that deep, going deep down, because most of the time when you get to the core belief underneath all of that, and those folks who are CBTers, this kind of sounds like that, right? Once you get to the core belief, sometimes it's not, I don't want to say that it's not rational, because it's very rational, but it's not, percentage-wise, it's not ever going to be a reality, if that makes sense. Or you get to the core of that and it's not that bad, if that makes sense. Like, oh, then I just won't be able to go to blah, blah, blah. Okay, and so if you're not able to go there, what does that mean for your life, right? Sometimes it's, I'm afraid that I will never be able to work and will be a burden, right? And so then I'll ask, and so if you're a burden, what would that mean about who you are and your identity? And we explore that and talk about those deep-rooted beliefs. And once we explore those fears, we realize, safety is already a concern for E and his community. And being a visible target makes him unsafe in the community. And so before navigating the community, E maybe felt like he had some semblance of control because he could run, he could, he could get away, he could move, but now that's limited. Also, there's some disappointment there as well. Once you get underneath it all, I'm disappointed that I can't do this. I feel like I'm failing. I feel like I'm letting people down, right? All of those things are coming. And then lack of income. When we think about what society says it means to be a man, when we think about what it means to be a young man, someone who enjoyed being a chef, right? We know that career is so tied into our identity and our value and self-worth. And so really uncovering all those things, which in turn can help E feel empowered. Like, you know what? You're right. I'm not a burden. My family is supportive. They want to take care of me, because if this happened to my dad, if this happened to my grandma, I would be taken care of them as well, right? And so exploring those, okay, you're afraid of this, but also what do you have in place that can help you get through this? You might be in pain, but what helps you to maybe ignore the pain, right? Is it watching a movie? Is it playing chess? Is it, anything? And something that I have done in my sessions, not in regards to patients who are going through PT, but I've used entire sessions for practicing of skills. And so if a client came in saying, listen, I didn't take my pain medicine today, I'm in a lot of pain, I'm like, oh, perfect. We won't talk about anything. We'll just do some progressive muscle relaxation. We'll do some deep breathing. We'll do some crossword or just to see how much, what is working, what's not working, like just to practice using those skills. As E was going through, session attendance did decline due to other obligations. He was able to find work, but then also, other things, life got in the way. And I believe one of the things that got in the way continued to be fear of tapering. However, and I'll pass it to Dr. Wenger.
Yeah, so he stopped coming to PT. He just stopped showing up and I didn't hear from him. We did not get to execute, we tried a little bit of tapering, but I agree that I think one of the reasons why he didn't come was because he was really confronted by this, mission we were on around tapering. And I do also want to make sure I give a shout out to his PA, his physician assistant. He was also very collaborative in this process and really on board with things and communicated a lot. So what happened is 2 years later, so he stopped coming to PT, and then 2 years later, he shows up in the clinic like, hey, Sarah. And he tells me that he stopped taking opioids by himself 3 months after his last visit in PT. So he stopped coming to PT, and 3 months later, he tapered himself off opioids and has not taken opioids since. He basically said, he wasn't feeling any progress. Those 3 months went by, he was taking the opioids, he was waiting for it to be cured, and it just wasn't like he wasn't making any progress. And so he decided to try the taper. He remembered that we had told him that opioids long-term didn't do a good job managing pain. He remembered everything that we said about how to taper and what to expect when he did taper. He was in a place, he was with his family over the holidays. He was sitting there in pain, and he just felt like everything that we said about long-term opioid use, he was just seeing it all, right? It was all happening just the way that we said it was. And so he just decided, well, I'm just going to taper like they taught me to, right? And he actually came in 2 years later because he was having a flare up in his pain. And he really was having these very thoughtful reflections about, when I exercise. He also remembered everything around exercise. So like when I'm active and I exercise and I stay strong, I have a lot less pain. When I kind of start sitting around more and I'm less in shape and I'm less strong, that's when I feel like the pain comes back. And so he's having a lot more pain when he's inactive and more pain when he stays active. So he's had these like thoughtful reflections around, what triggers pain, what calms pain down. And he's basically taken, I love the story so much for so many reasons, but first and foremost, it really shows the power of education. We could have tried a taper without the education and then just said, oh, this person's a drug addict or some super judgmental thing like that, right? But we had this idea, like, even if we're not going to be successful, I just want to make sure this person has information. So like going back to that chart, this person can take care of themselves, right? So, and I love that he was able to use all that and do it by himself, and that he could act on it when he was at a place where, the time was right. We all know, we in healthcare, we do such a good job of judging other people for not following through, but like, how good are we at following through on all of our goals, right? And we all know from personal experience that you can, intend to do something for a long time, but somehow or another, the stars align and all of a sudden you can do it. And we just don't know when that's going to be for somebody, but making sure that they have the tools and the information they need to do it when those stars align for them. And so I think it's a really nice story for that reason. I also think it's a really nice story from the perspective of 11th Street. The way that so it's a pro bono PT. So A, it's free. And B, because I'm not dealing with insurance, I don't have to get a referral and get authorization and make an appointment. I also don't have appointments. It's walk-in. So he was doing really, really well. And then he had this moment where he wasn't doing well and he just came right in and was like, hey, Sarah, I need to see you. And I love that the model of care we have at 11th Street makes space for that. And to me, that helps people take care of themselves so much better than imagine if he had to call his doctor, go in and get an appointment, get a referral to PT, it would be impossible to come see me. You can go to the next slide. So he said, he came in, he was pretty tearful when he walked in and he said, I'll never be able to walk normal again. Will the pain ever go away? Is what he asked me. And in that one session, I was like, well, is this, how often are you having these bad days? Well, he's not having them often at all. This is just this isolated flare up. It happens from time to time, but today, this particular day was bad. And again, I'm so happy that he was able to come in and see me on that day. But he was having, and this happens a lot with chronic pain where you can be doing well for a while and you get this flare up and it's like, oh, it's all falling apart. It's kind of like if you've been trying to quit smoking and you haven't smoked in a month and you have one cigarette and you're like, oh, I might as well smoke 12 packs. You're like, what is the point? It's not working. And so there's that, it's just scary, right? When that pain comes back, you're like, oh my God, it's never going to go away. I'm right back where I was before. But so we talked through that a little bit. Are you, you've had these flare-ups before, they go away, you're much stronger, we sort of talked through strengths. And the next time he came in, he literally danced into PT and was like, look what I can do, Sarah. And so we did talk about what does a good day look like? What does a bad day look like? Is a bad day going to be permanent? It's not going to be permanent because we have these good days. So focusing on, do we know what creates a bad day versus a good day? Can we get good at predicting good days and bad days? Because we know if you look outside and the weather's rainy and you got a bunch of stuff to do and it's going to flare you up, if you know what's going to happen and it happens, it's so much less traumatizing than, if it's just seemingly descending upon you, right? So I'm not going to read through all this for the sake of time, but he was walking up to 2 miles on good days. His balance was improved. His calf looked better. His pain, while it was bad when it was bad, generally speaking, it was, pretty good. And most days when he was staying active, most days he had no pain at all when he was active and exercising. And when he wasn't, the pain would worsen, but it was never as bad as it, originally was. And so I noticed a lot of improvements in self-efficacy and understanding of pain. I mean, he executed this whole plan on his own. Can't think of a better measure of self-efficacy. And really pragmatic, constructive expectations and perspectives on pain and function. So he was able to let go of that idea of being cured and really attached to this idea of how to care for himself and how to thrive.
And really quickly, what this case shows is that success can be measured in many different ways. And so we don't have to say, oh, a client was able to come to us for a full 24 sessions, met every single goal on the treatment plan that was developed, was consistent coming to therapy. That's not how we measure success. This client is a case of a successful interaction with the client. And so even if all of the things weren't met on a treatment plan, the client increased overall awareness of himself, of others, of the environment. He learned non-medication related coping skills. He was able to strengthen his family relationships. And he did attend therapy, even if it was sporadic, he did attend therapy until he terminated. Although at time of discharge termination of therapy, his use continued. He did secure employment. And as Sarah said, when he came back, we saw that he was able to be efficacious. And so we literally have 1 minute left to talk. And so this is a great place to end. But when you're collaborating, it's important to have shared values and understanding, right? It would be impossible for me to work with E if Sarah and I weren't on the same page with our value system, if we both didn't value community support, strengths-based, all of those things. Communication is key. And we can talk about, I know people have questions around confidentiality. We want to make sure there's shared decision-making that's rooted and grounded and centered in patient engagement, right? The patient is leading the charge. We'll make sure the plan is cohesive, as Dr. Wenger talked about earlier. A bunch of different plans from a bunch of different places can feel very overwhelming. And so having one plan that people are collaborating on can just streamline the process and make it seem so much simpler. Education, mentoring, supporting is super important. And then also we support each other as colleagues, right? When things may seem overwhelming or there are other challenges, we may have had a bad day with our patient or client. We're also supporting one another. Like, what, have you tried this? Let's talk through this. This could really mean that. So making sure that we're there for each other as well. We don't have time, but.
Yeah, I mean, I'm just putting this up again to say that we kind of, we sort of achieved our goal by doing what's on this slide. And I think the other piece in supporting each other, right, is that in a case that we might be having to, I hate calling it like challenging cases, right? But where we're struggling to help the patient get the outcomes that we want, the ability to work together just makes it easier for us to help someone and to really meet that patient's goals within our different spaces.
Yeah. So thank you for your time and attention. I guess we'll pass it right back over to Julie.
Okay, Dr. Ebony White and Dr. Sarah Wenger, you all are amazing. And I can only tell you like how many bazillions of messages I've gotten, direct messages from people wanting the video, wanting to make sure they have access. And I love oppression is the diagnosis. You are two superstars, and thank you for coming back a second time, Dr. White. You're terrific. We're so grateful. Also, you sort of embody interprofessional collaboration and what it could look like. Like it can look really amazing, and look at the impact that you're having on someone's life. So at this point in time, we've opened up the chat and we're inviting folks to ask questions of Dr. White and Dr. Wenger. And yes, you are going to have access to the video on our Epic YouTube channel for sure. And it might take us a couple of days to get that uploaded. But please, please, please enter your questions for Dr. White and Dr. Wenger. And I was just gonna say, I'm gonna let you manage that chat.
Okay. So Dr. Wenger, I don't know if you got private messages, but I got a few. So a couple folks thanking us for sharing about our backgrounds. That is important to hear and showing up authentically. Jennifer asked, let me scroll down. How is the flow of information managed amongst providers in regards to, in terms of patient confidentiality and informed consent? Do patients' clients at the center receive notification of the policy at time of admission intake?
So I think confidentiality is like an interesting topic because I feel like it's very different in mental health. And like, if I tell somebody what somebody's range of motion is, it has considerably less impact than talking about, their story and the things that you all are discussing in mental health spaces. So, I mean, I think to me, consent, like we do the whole, normal HIPAA thing, right? But to me, I'm like, we work as a team here. We think that we can provide the best care when we communicate with each other. I'm not going to share anything you don't want me to share. I'm happy to tell you what I'm sharing. Like I'll recount our exact discussion if you want me to. But I think it helps me be a good provider when I can communicate and like kind of we put our heads together. That helps me be a good provider, but it also helps us do that unified plan of care. You know, it helps us give you a plan of care that's like the whole you and not like the, you know, your ankle and your, you know, emotions and your social scenario. Like we're not splitting you up into these little pieces. And so when we can discuss with each other, that's really helpful in terms of us creating a plan for you. So that's how I do consent, but I'm going to turf it to you, Ebony, because it probably looks a little different.
Yeah, I mean, absolutely. So there are, I think most people on this call, well, not call, but you know what I mean? We know that there are certainly cases where we have to break confidentiality. And so all my clients, you know what those 3 instances are. Just so you all know, I just got a new computer today. And so I'm trying to figure out how to, navigate the chat and everything and move it, but it's not really working for me. But anyway, but also it's important for us, and I can speak for Dr. Wenger here too, patient autonomy is super important too. So even though we are collaborative and we share information, I certainly say to my clients, I ask, is this okay for me to share? And I respect it when my clients say, hey, can we keep this between us? Right? I still respect that, even though, we've already told them like we collaborate and we talk to each other. If my client says, listen, can you keep this between us? I will. And I certainly ask, hey, you know what, this is something, do you mind if I, have a talk with your PT about this, or your primary care provider about this? And most of the times it's sure, fine, yes, please. What is even better is when I say, hey, I think you should tell your PT this. And if you need support, I'll be there with you, or bring them down with you. Like, so making sure they know they have agency to share that information any way they please as well.
So I have a question from the chat about, what are some ways to troubleshoot when nurses, doctors, therapists, specialists don't share the same value systems or ideas about how to deliver or render patient care or client care?
We fire them. No. No, so one of the structures that we have is the SO. I think I spoke to this, is SOS, but like literally we challenge and call each other out. We call meetings with people. Hey, like, this is super important. What's going on here? What can we do to problem solve? Like all of that. Yes, and so we don't just walk around with grudges. We're human, so certainly there are some providers we prefer to work with over other providers, but we, call them in like, hey, we need an SOS meeting about this patient, or SOS meeting about this incident that occurred, and we come together as a community to problem solve it.
And this is just like really pragmatic, but if you're not in the same health system, which happens a lot, if you're trying to reach somebody from somewhere else, some people feel some kind of way about leaving their cell phone number, but I give out my cell phone number because I find like if they have to call me and leave a message and I have to call them back, and it's so hard to make that communication happen, and having like an actual discussion is so helpful. So one of the things that I do when if I try to call and I can't get a call back from somebody, I will provide my cell phone number and say, just call me, and try to have discussions. I really like the calling in idea. So when I definitely have discussions with people who, have like very judgmental ideas about why, patients might be doing something, or judgmental ideas about things. And so I just try to challenge that. Like, they might say, oh, this person just doesn't want to get better, or they are just drug seeking, or whatever they're saying. And I'll say, well, what I've found in my treatment is this, and this is what I'm finding. Here's why I'm finding it. Like, I just kind of go through my thought process. And I have found, obviously that doesn't work 100% of the time, but I think it's been my most successful tool for calling in.
One of our questions is also, how often were you seeing each other, working collaboratively together?
So, working in the center, it's different. So I don't know if you mean how often was, Sarah
Actually,
seeing.
how often was E, I'm sorry, E seeing Dr. White is specifically what the question is.
So it would, so there is, so some of this case is completely 100% what happened, and some of it is co-constructed, right? So for talk about confidentiality purposes, but if I were seeing E, I would see E weekly with a caveat. 11th Street works in a very unique way that if E's in PT and he sees me and he's walking out, we might engage with one another, right? Or walk down the hall or come in and I'm we're sitting there talking to, the client patient in the space. And so you have your scheduled sessions, you have the organic meetings where information may come up, even though it's not a counseling session, it's therapeutic. But it would have been once a week.
Okay, got it. Someone also asks, would aquatic therapy be appropriate due to chronic pain / ROM?
So it's interesting because, and I know Sarah's going to answer this, but I was going to say, I know we showed pictures of 11th Street and it looks super amazing. We don't have a pool. And I know it seems like we do, but we don't. But I'll turn it over to Dr. Wenger.
Yeah, I think that I think aquatic therapy can be really useful, but I don't think it's a must-have. And I would say a lot of our patients really don't have access. So it's a nice tool if somebody has access to it, but it's not, we can definitely meet our goals without it.
Got it. And
I can see some of the questions directly to me if you want me to do some of those, Julie.
Okay.
All right. So someone asked me, how does promoting interdependence look different than promoting independence? And so this sense of independence is a very Western idea or ideal, right? Where we want people to launch and be independent and self-efficacy and do everything by yourself. As an individual, you should be able to live and thrive. However, in most communities of color, interdependence is very valued, right? And so you're not successful if you're not helping the people within your community, within your family, right? If you're doing things by yourself, you're looked at as selfish or self-serving. And that's not something that's valued within the community. And so asking the client to think about, well, who can you lean on, right? And in what ways could you reciprocate? You may not be able to reciprocate in ways that you were able to before, like who can we maybe bring into the session with you? How can you, even the advocacy piece I talked about at the end, how can you share this information in your community so that the community gets stronger and has more knowledge as well? So letting the patient know, which is very not existential of me, that they're not in this alone, right? That they are having a shared experience, even though it's an individual experience. And I see people put, as substance use disorder, my first population I work with were people who are incarcerated. And if you worked with anyone who was incarcerated, you know that when an individual is incarcerated, a family is incarcerated, right? And so talking about that connected experience of that process. And so that's how I would do it, or that's how I do it.
Yeah, and I think just pointing out in E's case, right? When was he able to taper? He was able to taper when he was home with his family supported, right? So important, right?
Yeah. All right, Sheree said, I work with patients who have comorbid conditions and experience chronic pain. One of these comorbid conditions are substance use disorders. There is significant hesitation and oftentimes outright refusal to prescribe opioids as outpatient for pain management from a provider perspective, or only a short course with no taper. What recommendations would you both make? So I'll start with you, Sarah. What recommendations would you both make regarding management of their substance use disorders, assisting with pain management in a way that facilitates some level of physical relief? And how do you think providers can leverage community resources to collaborate with the care of these individuals?
That's a lot of questions, but I'll start by saying, honestly, the literature around tapering with anyone is scant, and the literature around opioid use with an underlying substance use disorder is also scant. So everything I'm going to say is based on scant literature. But I think, one of the things that's happened with the opioid crisis is like, oh, we can't prescribe opioids. So there's been like the pendulum has probably swung a little too far in the other direction. We're a little too stingy sometimes. And there has been a long-standing history of being stingy with pain meds with people who have, a history of drug use or other substance use problems. And there's a lot of stigma around that. And there's been a lot of under treatment of pain in that population for sure. I really think, when you're looking at how are we going to manage pain in that population, it really needs to be multi-pronged. I mean, that's what we focus on. And one of those prongs can absolutely be medication, right? But it's not medication alone. It's medication with, basically all the stuff we've talked about in this. Do we need strengthening? Do we need to move better? Do we need to manage stress? Do we need to find better connections? Do we need to maximize our support systems? Like, what are all of the things that we need to do? And we really stress this idea of having a toolkit. Like, when you have chronic pain, you need a toolkit that's really broad. Anyone with chronic pain will tell you, like, what I need on Monday is not necessarily what I need on Tuesday. There's good days, there's bad days. So even within one person, the tools you need vary day to day. And so I think the approach that we really take around pain management is helping patients develop that toolkit. So the way that I usually do that is I say, my job is to tell you what all the literature says, and your job is to figure out which of these things in what combination, when and why work for you. And my job is to support you on that journey as you figure that out.
Yeah.
So this is the part I hate, because I feel like we could go on with you two like for another hour with questions. And we can talk about this another time, but we'd love to invite you for sort of a post-event Q&A session if you're available. I know, Dr. White, you did that with us last year. It was really amazing. So I'm sure we've got some questions that people feel like they still want to maybe pose to you.